Hello, everybody from wherever you are in the world. Welcome to this webinar. We're thrilled to be hosting this with Mind Medicine Australia. And we have a wonderful group of people here to talk about the current achievements, opportunities, and challenges. And we also will leave plenty of time for questions, and you're welcome to put your questions into the chat. To begin with, I'm going to share my screen and I'm going to introduce the wonderful team we have here today. So to begin with, we've got Dr. Ali Kotler, psychiatrist, who's a board member of Mind Medicine Australia and one of the first psychiatrists in Australia to be prescribing and working with psychedelic-assisted therapies. He's also the Australian course director of our certificate in psychedelic-assisted therapies. Hello, Ali. And then we have Dr. Mike Winlo, who is a wonderful doctor from Perth at Emeria and the PAC Centre. And he and his team have also been treating patients with psychedelic-assisted therapies since the beginning of the year. And we recently saw their brand new psychedelic-assisted therapy treatment rooms, which was a wonderful experience. So hello, Mike. Then we have Dr. Lauren Macdonald from Imperial College in London, who has worked closely with psilocybin-assisted therapies in particular. And she is the intensive director, the director of intensives of our certificate in psychedelic-assisted therapies, and also one of the faculty of the world-class certificate in psychedelic-assisted therapies. A wonderful teacher. Welcome, Lauren. Then we have Peter Hunt.
Hello, everyone.
Who is the co-founder of Mind Medicine Australia. I'm Tania de Jong. And that was Scott Edwards, but he's somehow vanished off my screen, our executive officer. And we have lots of our team on here as well. And over 1,200 people registered for this webinar. Some of you are here now and some people are going to be receiving the recording. But wherever you're from in the world, we welcome you to say hello in the chat, where you're from. If you haven't been on a Mind Medicine Australia webinar before, please put your hands up and we can welcome you all. Hands up if you haven't been there before. Welcome to all of you. And we also would like to acknowledge the owners of the lands from which we all come, their elders past, present, emerging. And we also acknowledge all the wisdom keepers, the medicine keepers, the people who have kept the incredible wisdom of these ancient sacraments with humanity since the beginning of human civilization to the time now where we're living in some of the most challenging and divisive times in human history. Oh, what's that noise? And where many people more than ever are suffering with a range of different conditions. So at Mind Medicine Australia, we're thrilled to welcome all of you. I now will share the screen. Just one moment. And we'll move on to the next slide. Thank you, Lauren. And just a reminder that we are focused on the clinical use of these medicines. We present these webinars for educational purposes only. They're not medical advice. And the session will be recorded and will be shared on our YouTube channel. We're a mental health charity that was set up by Peter and myself 5 years ago, focused on psychedelic-assisted therapies to expand the treatment options available to doctors and their patients in Australia. The focus on psilocybin, MDMA and ketamine. For us, success means these therapies are an integral part of our mental health system, as in a first-line offered treatment by doctors to patients with full informed consent and full disclosure of risks and benefits of all treatments offered to patients. That we continue to achieve high remission rates, like the trials, 60 to 80% remission rates in many, many recent trials, and that will lead to a substantial improvement in our terrible and increasing mental illness statistics. Sadly, 1 in 4 Australians have a mental illness and 1 in 6 are on antidepressants. And as a charity, our most important initiative is to make sure that these treatments are accessible and affordable to all Australians in need, regardless of where they're based or their financial circumstances. Our strategy is to build the ecosystem. So for the past 5 years, we've been running a lot of webinars and events. We've been running a lot of educational programs, summits, chapters, all sorts of things to really make sure that people understand what these medicines do, the evidence from the trials, and we've worked together to achieve some extraordinary outcomes with many of you on this call tonight. We started the first professional certificate in psychedelic-assisted therapies in the Asia Pacific. We have a world-leading faculty, and we'll talk more about that shortly. That also provides professional mentoring for CPAT graduates, and there's many CPAT graduates on this call and also current students. We also helped secure $15 million of funding through the federal government towards research and development, which was the largest grant ever given to any, was ever given by any federal government in the world. And that's led to 7 trials, but there's many additional trials now taking place in Australia. And we work closely with the ANU to set up the first psychedelic registry to collect data on the current clinical treatments that are taking place by people like Dr. Winlo and Dr. Kotler. We're also interested in economic modelling of this whole field and talking with health insurers. We, of course, were responsible for the rescheduling of psilocybin and MDMA, making Australia the first country in the world to reschedule psilocybin and MDMA as controlled medicines. And we also have a patient support fund that we'll talk further about. And here's just some of the achievements that we can celebrate together. We could not have done this without many of you, and your support has been extraordinary. And you can see here that nearly 500 psychiatrists, psychologists, doctors, nurses, and other clinicians have been trained through our certificate in psychedelic-assisted therapies as well. So here's some of these incredible headlines, which were wonderful to see in hundreds of publications around the world. And for Australia to be a leader now in this field is very exciting for all of us. So I'll move on now to introduce Peter, who's going to speak to you next.
All right, so what I want to do is discuss where psychedelic-assisted therapies are going in Australia by reference to three periods. First period is really up to the rescheduling decision back in February 2023. The second period then takes us to, from the announcement in February last year to the present. And the third period is looking forward and thinking about where we can take these therapies through clinics across Australia and the issues that they give rise to. So just when you look at the timeline here, as Tania says, psychedelics have been with us for a long time, but the big event that occurred back in 1971 was the UN Convention on Psychotropic Substances, which Australia followed and effectively outlawed the use of psychedelics, both recreationally, but in medicine as well, with one exception, which I may deal with later. MDMA followed in 1985. It was added to the schedule. So MDMA, which was up to that point in time used a lot in couples therapy, became outlawed. And really from then onwards, research stopped. There'd been a lot of research in the 60s. It stopped because of lack of funding, because of government outlawing these substances and making it really difficult for researchers to get access to the underlying substances and the funding needed to fund trials. From the late 1990s, there were some very brave, frankly, researchers who started the research again. And over the last, 25 years, what you've seen is an acceleration in research. Now moving to the current times, My Medicine was formed in 2018 for the reasons that Tania mentioned. It was to really drive or seek to drive the use of these therapies in clinical environments. The first thing we tried to do was support psychiatrists to get special access scheme approvals, which were available from the TGA for unregistered medicines. And psychiatrists were getting those approvals back in 2020, but then they were being blocked by the states and territories who wouldn't recognise these substances as medicines, despite the fact that the TGA was issuing these approvals. That led us to 2021, when we started the rescheduling process. And the reason we started the rescheduling process is simply this, that by rescheduling the medicines from Schedule 9 to Schedule 8, patient access pathways become available in every state and territory around Australia. The same time in that year, 2021, we successfully advocated for a government grant round, really to help researchers in Australia increase the amount of research being done in this country. The rescheduling applications took us really 3 years. There were 2 lots. The first applications went in 2021. They were rejected at the end of 2022. We were immediately responded by new applications. And whilst they were not back at the interim stage, they were finally approved at the final stage last February. And you had that announcement which Tania talks about, and Australia becoming the first country in the world to reschedule these substances as medicines. So from prohibited substances, where they are, for example, in the UK and America, to controlled medicines. And that's a really exciting thing to happen. And it's really caught the attention of regulators and the medical sector generally in overseas countries, which I'll come to shortly. When you look at the terms of the rescheduling, they were pretty conservative, and frankly, we support that. I think when you introduce something as new as psychedelic therapies, which combine a medicine element and a therapy element, it's important to actually do it initially on a pretty conservative basis. The basis used by the TGA, which is what we sought, was psilocybin for the treatment of treatment-resistant depression as part of therapy, and MDMA for the treatment of PTSD as part of therapy. What the TGA did was make this part of the authorised prescriber scheme, which means that in order to prescribe, and the only people who can prescribe are psychiatrists, a psychiatrist must become an authorised prescriber. And to become an authorised prescriber, they have to first apply to an ethics committee, and in doing so, present to the ethics committee their protocols, where the medicine is coming from, the clinical environment where it'll take place, the therapists that they'll use, and so forth. And then once getting the ethics committee approval, they then go to the TGA, and the TGA look at the protocols used by or proposed by the psychiatrist, and they look at the Human Research Ethics Committee's approval, and all going well, they then approve that psychiatrist as an authorised prescriber. Now, that's quite a complicated process. For those of you who can recall what happened with medicinal cannabis, it was very much the same. In the early days, it was quite an unwieldy process. Now it's a very straightforward process. To help psychiatrists, we've put together detailed guidance notes prepared by clinicians, and they're available on request to any psychiatrist seeking to apply for authorised prescriber status. Just in terms of the rescheduling, the point I really want to make here is that it had enormous support. I think in terms of a rescheduling, psilocybin and MDMA had the most support of any rescheduling in Australian history. And as you'll see there, with our first applications, the support was around 500. That went up to 13,000 submissions with our second applications, the ones that were successful. There were so many submissions being lodged that actually the logistics for the TGA putting them on the website became really, really challenging for the TGA. Other point I just want to make here is that every now and then we get a few disgruntled researchers who suggest that they weren't consulted as part of the rescheduling. Let me just say that's complete nonsense. There were 2 public submission periods of 3 to 4 weeks each during each rescheduling round. They had plenty of time to present their views to the TGA. In fact, when you look at the 13,000 submissions lodged, about 6,500 for each medicine, in each case, about 500 came from clinicians and about 100 came from researchers. So researchers were like over 97% actually in favour of rescheduling. So if ever you read those sort of comments, just take them for what they are, probably pretty self-serving comments. The reality is researchers had masses of time to put in submissions. A large number did, and the submissions were overwhelmingly in favour of rescheduling. All right, so we get this momentous decision back in February 2023. So what's been happening between then and tonight, this webinar? Well, the first thing to recognise is that the February the 3rd, 2023 wasn't the effective date for rescheduling. The effective date was the 1st of July 2023. That's when rescheduling became effective. And it was only then that ethics committees would start to consider applications from psychiatrists for authorised prescriber status. So since July 1, we've had psychiatrists going through the authorised prescriber process. In early January, the first treatments took place. The first treatments were done by Dr. Kotler, who's on this call tonight, and Dr. Cassidy, who's a psychiatrist based in Sydney, but had to come to Melbourne for the dosing session, and I'll explain that in a minute. But quickly followed by the psychiatrist at the PAC Centre, which I'm sure Michael will refer to. In April 2024, I should say one of the bizarre things about this whole process is that you can't go to an official list of authorised prescribers. The TGA don't publish it, and that's an issue that we've raised with the TGA. So you have to understand the number either through your network or through presentations that are presented from time to time by the TGA. TGA, through their Chief Medical Officer, Professor Langham, made a presentation to the European Medicines Authority early in April 2024 to present what was happening in Australia. And at that point, she referred to 9 authorised prescribers. We think by June of this year, we'll probably be looking at 15 to 20, and by December, 20 to 40. And I'll explain what that means in terms of leverage very shortly. By the end of this year, we're going to have about 500 clinicians who've gone through our course, psychiatrists, psychologists, psychotherapists, and so forth, who are available for these therapies. That number, whilst it sounds quite a lot, given the likely demand, as you'll see shortly, we're going to need a lot more therapists than that to meet demand as we move forward. And just as with medicinal cannabis, which has now passed, I think, a million prescriptions, we are going to see, I think, a similar acceleration as people get more and more comfortable with the use of these therapies. So that's where we are now. We're actually seeing patients being treated. The pace of treatment in terms of numbers is starting to accelerate. The psychiatrists initially, understandably, wanted to be involved right the way through the process to properly understand it. But I think the reality is that most of the heavy lifting is going to be done by therapists. The reason I say that is because most psychiatrists actually don't have expertise in therapy. It's not what they do. The reality, I think, is that most psychiatrists are going to will need to be involved in discussions with the patient after referral on available treatment options for treatment-resistant depression or PTSD, diagnosis of the patient. If the patient wants to move forward with psychedelic therapies, then looking for contraindications, screening the patient. If the patient's on psychiatric medicines and it's appropriate to come off those medicines, then medicine tapering, and bringing in the therapists for the preparatory medicine dosing sessions and integration sessions. as I say, I think the psychiatrists are going to want to do the whole thing to begin with, just to get a feel for it. But I doubt whether they're going to want to spend, 7 to 9 hours in a room during the medicine dosing session with a patient, and all the hours that are necessary for preparation and integration. Bearing in mind that this is a very intensive model over a 3-month period. Now, the reason I give that explanation is what you then get, if you follow that model, is enormous leverage of psychiatrists. So if you think about it, when I talk to psychiatrists who have become authorized prescribers, and I ask them, how many patients do you believe you can have on your books at any one point in time? They talk about 40 to 50. 40 to 50 patients going through these therapies. The reason for that is simple, that the psychiatrist's time involved is probably 4 to 5 hours. The therapist time involved is probably 35 hours. So in order to have 40 to 50 patients on your books at any one point in time, you're going to need to have associations with a significant number of therapists who you can then bring in to do individual treatments. Now, 40 to 50 patients on your books at any one point of time over a 3-month period is probably somewhere between 150 and 180 patients a year. And as I say, in order to have that many patients, you're going to need a large number of therapists to support you. Second factor I just want to mention there is supervision. The Royal College of Psychiatrists, I think quite rightly, said that an authorised prescriber for their first treatment needed to be supervised. So what we've done there is we've arranged, and they needed to be supervised by psychiatrists who'd actually treated a patient with a particular illness, with a particular medicine, psychedelic medicine. So what we've done there is we've arranged a supervision structure so that a psychiatrist coming through can get appropriate supervision from psychiatrists who've already had experience in using this treatment modality. We've got to focus on ongoing awareness building. It never ceases to amaze me how few doctors, particularly general practitioners, really understand these therapies. And given that they are the main referral point, we've got to make sure that doctors right across Australia really understand the benefits of these therapies so that they can refer patients on to the psychiatrists. And we've got to take regulators along with us. No doubt over time, the model will be refined. There's currently discussions with psilocybin therapy between the benefits of a two-dosing model and a 3-dosing model. Different types of therapies will no doubt emerge to support the overall therapy. But that's what you want. I mean, you want innovation in the model, provided it's kept within conservative boundaries. And the last point I just wanted to make in relation to this page is ethics and safety. The model that's evolving is the medicine dosing sessions taking place in a clinical environment, 2 trained therapists in the room at all times, a doctor on hand, and the session being videoed so that if there's ever any accusation of untoward conduct made by either the patient or raised by one of the therapists, we can actually see very quickly whether there's any basis to that assertion. There have been commentary about, well, how do we make sure that patients are safe? That's an issue, by the way, right across the medical profession. Disciplinary committees are set up to deal with clinicians that have taken liberties. I think it's actually much harder for a clinician to take a liberty in this model, because during the altered state, as I say, you've got 2 therapists in the room, and you've also got the session being videoed. In terms of pricing, what we're seeing at this early stage is overall costs for psilocybin and MDMA-assisted therapy of somewhere between $19,000 and $25,000, which sounds a lot, but actually when you break it down to an hourly basis, virtually all of that cost is actual time cost of the psychiatrist and the therapist involved. The medicine cost is only about 5% of that cost. Now, having said that, $19,000 to $25,000 is a lot of money for many, many people. And that's particularly the case when you bear in mind that there's a higher incidence of mental illness amongst poorer people, disadvantaged people, than the rest of us. So Mind Medicine has been very focused on how do we make sure that people who want access to these therapies can afford these therapies. First thing we've done is we've established a patient support fund. The way that works is that the patient support fund will fund up to half of the cost of the therapy for a patient, but only if the patient's circumstances demonstrably show that the patient can't afford it. Now, that fund in turn is funded by philanthropists, including myself. There's a limited number of patients that we can fund out of that patient support fund, but at least it starts to enable poorer people or less financially well-off people to have a chance of accessing these therapies. The second thing we've done is we've had an ongoing dialogue with health insurance funds. And the good news here is that they're taking these therapies really seriously. And you may say, why? Well, the answer is the upfront costs may be high, $19,000 to $25,000. But if the patient goes into remission, the longer term costs are by definition not incurred. So what health insurance funds are basically saying, hey, if these remission rates that we're seeing in trials can be maintained, then actually paying the higher upfront cost saves money over the longer term. We're also speaking to DVA to get an item number for veterans, so veterans can be funded into this, and other specialist providers for first responders and so forth. And as we start seeing what are hopefully really good results coming from treatments, we'll then be making representations to government to start providing subsidies in the short term and longer term, obviously going on to the Medicare system. Medicine is available now in Australia, pharmaceutical grade GMP. There's two sources currently, both come from Canada. One is through Mind Medicine, the other one is through a listed company in Australia. There are other providers that are coming onto the scene. The pricing, I think, will be commodity pricing, so the pricing will be kept low. So medicine availability is not an issue. Now, Tania touched upon this at the start, but it's really exciting and something that we're very excited about. And that is that the Australian National University under Professor Paul Fitzgerald has agreed to establish a registry, which is now working. You can go to the ANU website and see information about it. What the registry is doing is working with authorised prescribers to enable the authorised prescriber and their patients to provide information on a no-names basis back to the registry. So the registry can collate information about the number of patients doing the treatment, the nature of their illness, how long they'd suffer from that illness, how they found the treatment, and the results post-treatment. The benefit of this system is firstly, it enables us all to see how the treatments are going. It'll highlight any issues that emerge in the early stages. But just as importantly, if the remission rates that we see in clinical practice are anywhere near as good as the remission rates in clinical trials, the information will enable us to advocate really strongly for governments to step up and start providing support. Now, the last point I wanted to cover before, I think, bringing in Michael Winlo to just comment on all of this is practice management. I talked before of the likelihood that some psychiatrists will actually devote a large part of their practice to psychedelic therapies and could have on their books at any one point of time 40 to 50 patients, 150, 180 patients over the course of a year. Each patient requires two therapists, two for the dosing session, one for the preparatory, integration, and final session. And the psychiatrist has got to have overall supervisory responsibility. Now, when you just think about the logistics involved in that, the logistics are actually quite complicated. You've got to have a number of therapists on your books. Those therapists have got to be available for particular times when the patient wants to do the treatment. That means that an individual psychiatrist will probably need 10 to 15 therapists on their books at any one point in time to manage all of that. What My Medicine is now doing is working on patient management systems to try and make that a lot easier. Now, that's a lot of information in a comparatively short period of time, but it might be good now to bring on Michael Winlo from Myria to just comment on how he's seeing psychedelic therapies, given that his PAC Centre was one of the early movers in providing these therapies. Michael, can you come on?
Sorry, you just unmute, Mike.
Scott, are you going to... Oh, sorry, let me just finish the last slide.
We just need you to unmute yourself, Mike. There you go.
Yeah, let me just finish the last slide before I put Michael on. One of the great things about Australia, and I say that with a degree of cynicism, is that we have this federal system, which means that we have a doubling up in relation to regulation as it affects the healthcare system. And that means that it's all very well getting the medicines rescheduled at the federal level, but they also need to have patient access systems available at the state and territory level. Now, the good news is that under our cooperative system, the changes to the poison standard under which these substances became medicines, they automatically flow through to the poison standards of every state and territory in Australia. So as of today, every state and territory of Australia recognises these substances as medicines. Now, in terms of Victoria, Queensland, Western Australia, and the Australian Capital Territory, the response of the state and territory government has been pretty progressive. In Victoria, all the psychiatrist needs to do is give 7 days notice that he intends to prescribe to the Department of Health. He doesn't need to wait for a response. In Queensland, there are no further regulations. In Western Australia, the psychiatrist needs a permit, but that's straightforward, and Michael can talk to that. And the same is true of the ACT. So for those first 4 parts of Australia, very straightforward. New South Wales started off by being much less progressive. They said that these therapies could only take place in a mental health hospital. And the problem with that is obviously cost and capacity. So we've gone back to the New South Wales government, made representations, and the net result of that is they're putting out new regulations for review. And if they're passed, and we're hopeful they will be passed by mid-year, what those regulations will say is that psychedelic therapies can be conducted either in mental health hospitals or in licensed clinics. So in that way, psychiatrists with their own clinics or access to clinics will be able to do the dosing sessions. South Australia, it's unclear that the place where the dosing session has to occur has to be approved by the South Australian government. But again, we're not seeing major roadblocks there. It seems to be a process, and Tasmania is very similar. So whilst we've got them in orange, it's simply, I think, a more laborious process rather than a major hurdle. And I think over time, we're going to find that every one of these states and territories are green. In other words, at the state and territory level, it's all streamlined and the approaches are sensible. And by the way, that's exactly what happened with medicinal cannabis. So without more, Scotty, can you bring Michael Winlo onto the spotlight?
One moment. Hi, Mike.
Hi, Peter. and team.
G'day, Mike. Have you
Can
got?
you hear me okay? Yeah, would you like me to react to some of what you said there, Peter, maybe?
Yeah, if you would, Mark,
Conversation.
just your thoughts.
Sure. Yeah, well, I guess, first thing to say is, Myria has been a company for the last 4 years, very interested in this challenge of bringing new treatments to patients who weren't responding to their standard of care treatments. And so we've sort of developed an expertise, if you will, a deep interest in how to facilitate access to recently rescheduled medications. And we started with the cannabinoid-based products a few years ago. And for the last 3 years, I've been preparing for the delivery of these new treatments as well, particularly where the evidence is emerging but not yet complete. And so there's a huge patient need for new options, particularly in those who aren't getting benefit from their current treatments. But there's also a large learning opportunity as well. And so we've taken this view that this is a tremendous opportunity also to really pay attention with patients to kind of advance the field as well. And I kind of wanted to start there because I think one of the opportunities is for medicine, healthcare providers to really get much more engaged in the learning with patients activity. And we have the technology, we have the approaches, there are skills and resources, they're unevenly distributed, but it is possible for clinics to become much more active participants, I guess, in the advancing and learning of these treatments. And so, one thing I'll say is that this is a really important challenge to get right, is this final mile of delivery to patients. And as exciting as these opportunities are around rescheduling and these new access pathways that are now legally available, there is really still a great deal of coordination required between clinicians, between specialists and therapists, between clinical sites and regulators, between sites and drug supply manufacturers as well. And so I think looking forward, one of the areas that I think I'm excited to see come together is this great cooperation between all these different parties and different skill sets to be able to provide these treatments safely, but also to be able to do it in a way that allows us to learn with our patients and advance the field as well, and hopefully make it more efficient and more accessible for those who may stand to benefit. We got involved in a clinical trial in October last year. We are preparing for our 8th patient through that service. We are encouraged by the early results, but we are certainly seeing a great range of patient reactions, mostly very positive, but it is a reminder that there's still a lot to learn. We are following in the footsteps of those who've done the great work before, particularly the MAPS protocol, and our focus so far has been very much on MDMA-assisted therapy for PTSD, although we have the infrastructure and team capable of using other treatments as well. But that's been our core focus at this point in time. And so I'd be happy to speak about that, about some of the ways that we're tackling these coordination problems. But I will say that this will also be a catalyst of change, both in how we deliver mental health treatment, because of all that extra resourcing and effort required to provide these treatments safely and efficaciously. And it also requires a new way of thinking about mental health treatment. And that's one thing I'm really excited to see and have been encouraged by, is this reevaluation of mental health care towards more intensive, higher touch, more impactful treatment, which these treatments really facilitate, rather than the drip-fed sort of palliative approaches, which has sort of beleaguered the sector for such a long time. And I think this is just the very beginning of hopefully a number of shifts that will take place that will not only help patients get well, but also help our health system adopt and embrace more of these innovative approaches as well.
Thank you so much, Mike. We were thrilled to catch up with you recently in Perth and see your wonderful new treatment rooms as well. Fantastic. And people will be able to ask questions soon. So we're going to move on to the next slides and talk about the certificate in psychedelic-assisted therapies. And we're seeing an enormous amount of questions about the training. And we're going to be introducing Dr. Kotler and Dr. Macdonald in a moment to talk about this. And of course, we have Scott Edwards here also to talk about this. But Our CPAT program is the leading program of its kind in the Asia Pacific. It covers all the knowledge and skills required to safely deliver psychedelic-assisted therapies. And by the end of December, we'll have trained over 500 health professionals, doctors, a range of different types of therapists. I'll talk about that in one moment. And we are covering the medicinal use of MDMA, psilocybin, and ketamine. There's 14 weeks of online classes that takes place over a 4-month period, so can fit very well with your professional practice. Most of the course takes place on Sundays, and those sessions are recorded. And there's a 6-day in-person residential, which I'll ask Dr. Macdonald to speak about in a moment, which is often described by students as the absolute highlight of the course, though they love the whole course. Professor Nutt described our course as the leading course of its kind in the world. Applications are open to psychiatrists, all kinds of medical practitioners, GPs, palliative care, addiction specialists, etc. Psychologists, psychotherapists, counsellors, nurses, RNs, all kinds of nurses, mental health nurses, social workers, OC therapists, registered allied health professionals, sometimes art therapists. So we've had Chinese medicine doctors and others be part of the course. So this is our extraordinary faculty, which is led by psychiatrist Dr. Geeta Vade out of New York and Dr. Ali Kotler, who will speak about the course in a moment as the Australian course director, our residential facilitator, Lauren, as I mentioned and introduced before. And we also have Dr. David Rizzo, who's heading the psychedelic psilocybin programs at Imperial College London, coming to Australia in June to facilitate the intensives with Dr. Macdonald. And Dr. Geeta Vade will be coming to facilitate the intensives in October and November with Dr. Macdonald, which is extremely exciting to have these world leaders coming to actually be with students in the course for a whole week in Australia. Then we have people like Professor David Nutt, Dr. Bill Richards, Dr. Rick Doblin from MAPS, Professor Arthur Christopoulos, the head of pharmaceutical sciences at Monash University, Dr. Bessel van der Kolk, Alicia Skye, Dr. Gabor Mate, Dr. Jim Fadiman, Dave Nichols, Philip Wolfson, Barry Walker, Sarah Reed, and others. So Dr. and Rabbi Terza Firestone, who's missing off this slide, but who is a superb psychotherapist based in Colorado. So the next intake begins on July the 21st, and places are filling fast. The applications for this next intake close on May the 31st. And we have a very special offer today that we will give $200 off the application fee. So there's just now a $50 application fee if you apply by next Monday, the 20th of May. Now, for those of you who are working in environments that are high needs and perhaps in need of financial assistance, we have a few financial assistance places available. And if you need that support, you can ask for that as part of your application process. But we urge you to apply now and have your interview as soon as possible so that you can be part of this upcoming intake and get to work in person with Dr. Geeta Vade and Dr. Lauren Macdonald at the intensives, and Dr. Kotler, who will be at the intensives as well. So actually, I'm just going to go back to that, and I'm going to now bring on, we'll stop the share for a moment because we're going to bring on Lauren and Ellie now to join me to talk about the course. And I think, Ellie, we might start with Lauren. Where is she? Hello, Lauren. Can you unmute yourself there? And we'll unmute you as well, Ellie, at the same time if we could. So Lauren, would you like to talk a little bit about the course from your perspective, what you love about it, and also a little about the intensives and why you feel it's such important training?
Yeah, thank you, Tania. And hello, everyone. Lovely to be here with you. So yeah, as Tania was saying, my background is in psychiatry, and then for the last few years, I've been working on the clinical trials at the Centre for Psychedelic Research at Imperial. And it really is just a huge paradigm shift, this way of working and really supporting people with their mental health and well-being. And this course is unique, I believe, in the sense that it's not just focused on building up your knowledge and making you a competent, safe, ethical psychedelic practitioner, but it's also really very transformative in the sense that we want you to kind of evolve as you're going through the training. It's a deep immersion, a kind of self-inquiry, and really enabling you to embody the qualities of a psychedelic-assisted therapist. Because as I said, this work is really unique. It's not like the way I used to practice psychiatry and psychology. It's very, very unique in the way that we need to be. And it is really this sense of, a new way of being, like how are we showing up in the therapy room for our clients and how are we supporting them. And I'm especially passionate about the in-person intensives because it's an opportunity for all of the online knowledge and skills to really be practiced. And not only kind of practicing through role plays and various different ways, but also it's, again, an immersive experience for yourself. So you can expect to leave the in-person residential changed in some way, hopefully expanded, and really with the confidence to go out and be an effective psychedelic practitioner as well. So yeah, I think it's I'll probably leave it at that for now, Tania. But
no,
yeah,
that's excellent, Lauren. We're so honoured to have you as part of this program, and the feedback about your teaching is exceptional. And we're very much looking forward to seeing you very soon, and this next round of intensives and the next one after that. And Dr. Kotler, we have Dr. Ellie Kotler here, who will talk about, firstly, well, Ellie was, one of the first 2 psychiatrists in Australia to treat patients with psychedelic-assisted therapies. Ellie, how was that?
Intense.
But you've had some really great outcomes, which is so exciting, and we're thrilled for you. Do you want to talk a little bit about the course and why you believe it's, well, you were in the first intake of the CPAT course, of course, but please go ahead and discuss whatever you'd like in terms of the training.
Sure. Thank you. Thanks, Lauren. Thanks, Tania. Hi, everyone. It's a challenge to speak in a few minutes about psychedelic-assisted therapy and the course that we're involved with, but I'll do my best. Potentially, like a lot of people here, I was attracted to psychedelic-assisted therapy due to what I saw as really significant shortcomings in the current paradigms and models that we use to conceptualize and understand suffering in our mental health system. And I thought I would just express a few thoughts about what's been coming up for me in the significant aspects of psychedelic-assisted therapy that have been coming up for me as I've been trying to help my first few patients. So one is, and these are, I guess, things that if you connect to, maybe psychedelic-assisted therapy will be an interesting path for you. And even if you don't connect to it, it could still be an interesting path. But one is to really be interested in the mind and exploring the mind, particularly the non-conscious aspects of the mind, and the brain is always important. It's always important to stick up, slides of brains, but really this is about exploring people's inner experiences with them. It's about trying to understand humans rather than understanding diagnoses. And that's it's a very, very different approach. It's about, I think, walking together with the person you're trying to help, or even behind them at times, rather than being in front of them with the answers. We don't have the answers. We try and psychedelic-assisted therapy is about trying to help people find their own answers, rather than the therapist having the answers. It's about facilitating healing and integration rather than treatment, which again are quite different things. Focusing on the person as a whole rather than symptoms. And it's about learning, and this is something that we try and emphasize in the course, that it's not necessarily, we teach knowledge in the course, in the CPAT course. Obviously, there's things that people have to learn, but primarily the knowledge really comes from learning about oneself, having one's own therapy or pushing through one's own challenges. And so, the knowledge is from a different place as well. It's not necessarily all about learning information from outside of us. It's often more about trying to, understand things from within ourselves while we're sitting with someone else going through a profound experience. So those are the things that I've been thinking about. I've also been thinking a lot about the paradigms we use to understand and conceptualize mental health difficulties. And, we can talk about this for hours, and if you do the course, we get to talk about this for hours. But potentially our current psychiatric categories are not the best ways to conceptualize human suffering. They have significant shortcomings and potentially put up barriers, and this is really, I think, about a chance to change the paradigm that we use in our current mental health systems. So I might thank you.
Well, so folks, there's gazillions of questions here, and I'm just going to share the screen and go through just the last couple of slides, and then we will open this up for questions, and we can see that there's a lot of questions. So we're going to try and do them very quickly and bring in the group who's here to answer relevant questions that we can, as many relevant questions as we can in a moment. They're all relevant, but we'll try and amalgamate them as much as we can. So the special offer, as we mentioned, and then our upcoming events, our patient support fund. So there's a lot of questions in the chat about the cost of these treatments. And Peter, in a moment, I'm just going to ask you a couple of questions that I've seen in the chat. But Mind Medicine Australia has set up a patient support fund, and we really ask all of you to support this as much as you can through small and large donations. We can't do this alone, and many of you are generously donating. And this will provide up to 50% of support for a patient's treatment. And it's also important to note that part of the treatment can also be rebated through therapy, through your private health insurance, and also, I think, through Medicare. So there is a certain element and part of the treatment that can already be rebated. But the patient support fund is there for those who are really struggling to afford these treatments and who have an authorised prescriber who's ready to treat them. We have a number of excellent upcoming events. On Wednesday, we have Dr. Alberto Villoldo, who is a wonderful doctor shaman based in Peru. And then you can see the rest of our incredible global webinar series. And we also are now hosting free weekly community meditations on Friday lunchtimes. And we also have a wonderful podcast with lived experience. So if any of you have lived experience and would like to be on our podcast, we'd be very happy to welcome you. And yes, this is our mental health epidemic and why we're all here, because we want to stop the suffering. So we're going to open up now for questions. If you get that off the screen, and we'll start. I've seen a question in the chat, a couple of questions about interaction and Department of Veterans Affairs. And so we did meet with Veterans Affairs. Well, we have been meeting with them over the last few years, but we had a very good meeting with them last week. And there's a lot of movement with Department of Veterans Affairs. Peter, do you want to just very briefly summarise that? Because we've got so many questions here.
Yeah, just very briefly, like we all know that veterans really do it very tough. I think it's one veteran commits suicide a week. They have far worse comorbidities than most people suffering from mental illness. So we really do need to help them. The primary body that's focused on providing them with funding for medical treatments is obviously the DVA. We've had ongoing discussions with them now for a number of years. I think they are drawing a lot of confidence from the fact that the medicines have been rescheduled and treatments are starting. And frankly, they're coming under more and more pressure from the veterans themselves, who are just saying, these treatments should be available to me. I just can't afford it. I need funding from you. So I think we're going to find that DVA in the not too distant future do provide a funding number. And as soon as they do that, that will mean that veterans can access that funding through in conjunction with their psychiatrists.
Thanks a lot, Peter. There's also quite a lot of questions in the chat about the cost of the treatments. However, well, we haven't arrived at those costs. That's what the clinicians and the clinics are charging. Peter, do you want to just talk about why that costs that and how people can then work with potentially the patient support fund and also their private health and so on to get that, and why it costs so much money?
Yeah, look, again, you can draw parallels with medicinal cannabis. The price of medicinal cannabis is coming down as there are more and more people taking medicinal cannabis, and there are more and more providers. At the moment, there are only a few authorized prescribers, and there are a lot of people who want access to these therapies. So in a way, if you're an authorized prescriber at the moment, you really have a lot of flexibility in terms of what you can charge. Now, to be fair to authorized prescribers, what they're doing is they're going into a new area of medicine that takes up a lot of time and effort. Anyway, the net result is at the moment, we're seeing charges of somewhere between 19 and 25. I would hope that over time that will come down as psychiatrists and therapists become more comfortable with the logistics around these therapies. But again, it's really important to look at that figure in the context of what for many people is lifelong suffering. If somebody is suffering badly from treatment-resistant depression or PTSD, they may not be able to leave their own homes. They may not be able to keep down a job. They may be on NDIS payments or other government welfare. Over time, inevitably, governments will step in if we see strong remission rates, but we've got to cover the period from now to the time that governments step in. And that's why we have a patient support fund. That's why we're talking to the health insurers. That's why we've got a registry in part, so we can collate real-world evidence to use with government. We're in that sort of no man's land at the moment where, unfortunately, in the absence of our patient support fund, somebody who is financially struggling will find it difficult to access these therapies. I just want to add one comment though, Tania, and that is that there was a comment on the chat that NDIS funding wouldn't be available. That's not what we're now hearing. We're now hearing that in certain circumstances that there is a component of NDIS funding that could be available for somebody who's suffering one of these two mental illnesses. So that may well be an avenue for people who aren't well off.
And as Peter mentioned earlier, there's a number of health insurers who are really pushing this whole field forward. So I expect to hear some announcements very soon about those. There's also been questions in the chat about other indications for the use of psychedelic-assisted therapies, including eating disorders, autism spectrum disorder, and many of you will know that there's trials taking place for these sorts of conditions, and also early cognitive decline, early stage dementia, obsessive compulsive disorder, Parkinson's, stroke, cluster headaches, fibromyalgia, and so on. So there's going to be an enormous amount of movement in this field as there's so many trials taking place around the world. There's also questions in the chat, and Scott, I'm going to ask you for you to bring some forward in a moment too, but there's questions in the chat about the difficulty really reaching psychiatrists or getting a psychiatrist. But as Peter mentioned, psychiatrists like Dr. Kotler and Dr. Cassidy and Dr. Mike and his psychiatrists at the PAC Centre, they all have a way of seeing a number of patients over a period of time, and they will make time for you if you're properly screened by them, and if you need to have this treatment, please reach out to us and we will connect you with them, with the authorised prescribers. There's also some comments in the chat about the fact that only psychiatrists and clinical psychologists can be in these treatments. That's not actually accurate. And Peter, you might just like to comment on that based on a conversation with the TGA last week.
So just say that again, Tania.
So that this treatment does not have to just be supervised by a psychiatrist and clinical psychologist.
Yeah, look, this is a new treatment area. So, we're bound to see a period where the rules get streamlined and better understood. When the rescheduling happened, there was a lot of vagueness from the TGA about the role of the psychiatrist. And there was an indication that the psychiatrist had to be involved in every step of the process. In other words, the medicine dosing sessions, the preparatory sessions, the integration sessions. Now, if you think of the cost of psychiatrist time, and you think of the lack of psychiatrists that we have in Australia, or the shortage of psychiatrists that we have in Australia, that's probably not the greatest use of a psychiatrist's time. That then led to the TGA talking about, well, no, a psychiatrist hasn't got to be involved in every step. They just have to have overall supervision responsibility, but they don't need to be in the dosing sessions and the integration sessions and so forth. That then led into who could be a therapist. The initial indications were they had to be clinical psychologists. We went back and said, well, there's a problem with that because there's a lot of great therapists who aren't clinical psychologists. The next step was, well, they've got to be APRA registered. And again, we made the comment, that's good. That's expanding the field, but actually there are a lot of therapists who aren't APRA registered. So that whole area now is being reconsidered by the TGA. And I'm hopeful what we'll see is a much broader class of therapists available to do these therapies. But again, I think sometimes people think that, a system changes and automatically everything is in place to make the system work as efficiently as a system that's been around for 30 years. The reality is, what we're seeing are teething problems, but they're gradually being streamlined. And over time, we're going to see a really efficient system, but it'll take a bit of time to get there.
No, thanks for that. Scotty, do you want to just share a couple of other questions that are all common themes that are coming out through the questions that Ali and Lauren and Mike and others can respond to?
Yeah, for sure. I think there's a great question here that's come through. I'm trying to understand the logistics and environment in which treatment sessions will occur. I can't imagine a hospital being that conducive to the psychedelic experience. Is there a vision for setting up more spaces and centres where sessions can occur within natural environments, trees, nature, etc.? But I feel like Ellie and Mike, perhaps this is a great one to speak a little bit about what you're both working on in terms of spaces to deliver these therapies.
Ellie can't.
Ellie, you're on mute.
Oh, Mike can. Mike, go ahead, Mike first. And Ellie.
Yeah, I think really intriguing question. Of course, great interest whether these treatments can be provided in sort of more natural settings, and certainly a lot of thought and attention is placed on the environment in which the sessions take place, so that they are low stimulus and relaxing. One thing I will say is we're quite constrained by some state legislation around the drug on site. Because of our protocols, we are required to have a safe on site. It needs to be carefully installed. We have a very strict clinical governance process that requires 2 clinicians to check in the medication that's only given on site under direct clinical supervision. And so some of these hurdles are imposed on us by the state government. Some are required in order to comply with what the TGA expects of us as well. So there are still some heavy constraints at the moment. Again, perhaps to Peter's point, more a product of the conservatism and the early phases that we're in. But I think over time, as the results prove themselves and people become more familiar with the treatments, then we may see some changes to that.
Yeah, and I guess I'll just add that definitely you want to make the room as non-medical as possible. As Mike said, there are certain constraints at the moment. But I will also say, and particularly the way I guess I work, it is most of the time it is quite an internal process for a lot of people. Obviously not everyone's different, but a lot happens in here. And and obviously the setting is extremely important, but you know, so for example, I do it in a hospital, but me and my co-therapist bring in a couple of plants into the room for the dosing day. But I don't even know if the people notice there's a plant there. You know, maybe that's more for me and my co-therapist, because a lot's happening in there. But you know, maybe one day we'll be able to do it outside. That would be interesting in nature. But I think we're a fair way from that due to the restrictions.
Thank you. Scott, could you bring forward any more questions, potentially for Lauren and others to also respond to?
Sure. I'm just trying to scan through here to see what I can find.
There's a lot of questions there.
There are a
I
couple
did
of
scan one, if you don't mind, that I think is worth just raising, and that
Yeah,
was
go for it, Mike.
yeah about what, you know, tracking adverse events with patients, and I think that's a really important question. I think the question was, you know, are adverse events tracked and monitored? They absolutely are in clinical trials, and all authorized prescribers are also obliged to report on adverse events at least every 6 months for every patient. So there is a registry, there's a formal process for doing that reporting. Clearly a very important part of the whole real world sort of evaluation of these treatments. So I did want to just to reassure whoever asked that question that that's
Okay.
a key piece.
Hey,
of
Mike,
journalism.
I'd love you to just very briefly talk about that case of that patient who could get out of her house again. Would you mind just sharing that with everyone? Because it's such a beautiful story.
Yeah, I'm hesitating just because I understand that I'm probably limited in what I can say about the treatment. One of the other constraints the TGA puts is because these are unregistered products, therefore there's no single MDMA product or a psilocybin product yet to be registered with the TGA. That there are restrictions on what people can say publicly. That individual's on a trial. We had some remarkable outcomes from some of our patients on study, which we hope to be able to present to the world soon. But we're encouraged enough to keep going with this.
Good. When are you going to be presenting some of those outcomes, Mike?
Yeah, I'm hoping by the last quarter of this year, around September.
Great. Well, we'd very much like to share that with everyone. Scotty, what other questions are there? I can't look at it all because there's so many questions here that I can't.
One that I can see multiple times being asked is a few people asking about ayahuasca and why that one isn't being included in this discussion, and perhaps that's one that can be just addressed quite quickly.
Yep.
That's very quick, because the trial evidence at the moment doesn't support it, and in order to get a rescheduling through the TGA, you've got to have lots of clinical data. And you know, ayahuasca, DMT is currently Schedule 9, and it's going to take a lot of trial work before I think you can get a rescheduling through. But hopefully over time.
And then there are a few questions in here about practitioners having a personal experience with MDMA or psilocybin, and whether that's relevant or helpful. So I'm not sure if Ellie, if you want to speak to that at all.
I think we'll ask Lauren, because she's
Yeah, for
she hasn't
sure.
had as much time on the screen, so I want to give her a chance.
So you need to unmute.
Yeah, perfect. Thank you very much. Oh, it's such a juicy topic, this one. I think, yeah, it's interesting. I definitely used to be of the kind of belief that if you're working as a psychedelic practitioner, that you should have your own psychedelic experience, just so that you are vaguely familiar with the terrain and what people might be experiencing. But then there's also this issue of disclosure with your patients, because so often the question will come up, you know, have you taken psychedelics? They want to know, and often that can be really reassuring for somebody if you're about to guide them, if you say, yes, I have. But in terms of the research setting as well, you know, in terms of the bias you're bringing in, historically, it's researchers were not meant to disclose if they had personal experience. But you know, this work requires honesty and transparency. So I think it's actually difficult to kind of not be upfront and honest with your patients about this. And I've worked with some amazing co-therapists who haven't had any psychedelic experiences themselves, and they've still been incredible to work with. So I think that you don't have to have had these experiences, but I would say that I would recommend it. I think that there's many ways to experience an altered state, though. It doesn't have to be through psychedelics. It could be holotropic breath work. It could be ecstatic dance. You know, there are other ways to experience it. But we are actually, as part of Mind Medicine Australia, we're putting on a retreat in the Netherlands this July to give CPAT graduates the opportunity to come over and experience one of the psilocybin retreats that I facilitate. And it is just an amazing opportunity, if you haven't experienced psilocybin in a safe setting, to come and have that experience. So that's one thing. And I just wanted to actually tag on to the other question, if that's okay, which is around the setting of where we're doing this work. And obviously we're kind of trying to shoehorn very sacred work into the clinical setting. And Imperial, we did do our best to try and make the clinic less of a clinical space. We brought in plants, we had kind of soft lighting, nice furnishing. We tried to make it as kind of welcoming as possible. Things like essential oils as well. So there's real scope to honor the fact that this is not this work, especially if you're working with psilocybin. It's we don't want it to be sanitized, and we don't want to strip out the sacredness of working with these compounds, and also honoring Indigenous wisdom as well, and the way that, you know, historically this has been done in the group setting. So I think that's another area that I'm really passionate about, is how in the future are we going to make it more affordable and accessible, and how the group model will come in at some point. So there's a lot more to say on that, but I just thought I'd touch on that.
No, thank you, Lauren. That's absolutely invaluable, and hopefully these retreats in the Netherlands are going to be annual events. So we look forward to helping you with those. There's also questions here, Ellie or Mike, about the medicine tapering. A very common question about medicine tapering, and there's been some research recently that suggests that may not be as critical. But Ellie or Mike, I'd like you to briefly comment on that. Ellie, you're muted.
Well, can you hear me? He can't unmute himself.
I think he's got a problem.
Might be the challenge.
Hi.
Go, Ellie. Oh, I was going to say, is that tapering is really important. It's currently recommended and probably the most common practice, purely because the clinical research to date has typically followed that path. There are studies underway to see whether the medicine attenuation and maybe some of the side effects that people are cautious about may not manifest, or there may be adjustments to treatment protocols that might account for people to remain on their psychotropic medications. At this point in time, that we follow the practice of the trials that have been completed, which does require tapering, and that can be very challenging. So it's a very attentive, very critical period for us for those patients, and that might be, depending on what treatments people are on, can be somewhere between 4 weeks to 2 months of gentle tapering, and usually quite tailored to the patient's needs for that, with the belief being that once you're off your psychotropic medicine, you're likely to get the most potent effect from the drug treatment.
Thanks for that, Mike. Scotty, is there any other questions that you want to bring to the table from the chat?
One question that I do think is really interesting is to jump off the introduction of the sacred that Lauren's brought in. When spiritual effects come up from a psychedelic experience, potentially facilitated by a scientist or scientifically trained facilitator, how do we discuss or debrief this without a background understanding of the spiritual teachings and Indigenous wisdom? And perhaps, Lauren, you'd like to speak about how we address that in the CPAT training, and how this is sort of handled.
Yeah, lovely question. Thank you. So essentially, this is psycho-spiritual work, especially when you're working with psilocybin, and then MDMA and other substances as well. Like, so often spiritual existential issues arise, and often people maybe don't have a spiritual framework to make meaning of these experiences. So as therapy guys, it's not that we're pushing any particular framework onto our clients, but we're just providing a kind of a space for it to be explored. And this is all kind of covered. It's a very nuanced, very complex topic, essentially, because it's like I said, a huge paradigm shift away from traditional psychiatry to really broadening our understanding and being non-judgmental, really allowing space for people to explore the mystical and these existential issues. I don't know if that answers it.
That's a great answer. Any other questions, Scotty, or Mike or Ellie? Anyone want to make any last comments? Because I'm conscious of the time and we are a little bit over time now, but I just want to see if there's any wrap-up comment from any of you. If not, we'll just put a couple of quick slides on the screen to finish. There's still people entering the webinar now, which is quite interesting. Peter, did you want to say anything? Oh, Mike, Peter,
Yeah,
Mike.
I did, because I mean, somebody's just made the observation that thank goodness we've just seen the word sacred being used, and I agree with that. I mean, I think the real risk with these therapies is that they become too clinical, and they lose that magic because of it. And at My Medicine, we're really conscious of that. The experience a patient goes through, it's described often as one of the top experiences of their lives. They're going right into themselves and exploring themselves. It's an extraordinary process. But to get things through regulators, we have to speak the language of that they understand. And if I go into a regulator and start talking about the sacred nature of these medicines, they're going to very quickly turn away and focus on other things. So what we've done at My Medicine is we've gone in hard with all the clinical data, of which there's an awful lot now. We're very focused on safety. We've got around us the most extraordinary group of advisors. But again, picking up something that was said earlier, we would love to see these therapies being available in more natural environments. That's where they should be done. But I think we've got to play the game. We've got to go along the medical model and work the medical model and educate, because this is a massive shift that we're asking many regulators in the mental health sector to take. The TGA are used to just looking at medicines. Now they've got to look at medicines combined with therapy. That's a massive learning curve. It's a massive learning curve for every regulator around Australia. To get to where we want to get, we've got to speak their language, knowing that the end game is to make sure that at all times the spiritual, sacred nature of these medicines is recognised by the therapists involved with the therapy, and the patient can go through that magical experience. So we're very alive to it.
Thank you, Peter. We're just going to, Lauren, Mike, or Ellie, does any of you want to finish up with anything at all? If you do, then please unmute yourselves if you can. If you can't, wave to me and we'll try and unmute you.
I mean, I might just reinforce that. I mean, I was kind of, we don't have much time to talk about these things, but when I was talking before about, different paradigms in how to understand mental suffering, and I also spoke to the idea that, it's more about the person doing the therapy than necessarily something that they've learnt, the half-life of MDMA or something, which is important to know, but that's not going to make you a good psychedelic assisted therapist. So these are all sorts of things that, as Peter and Lauren are saying, we take really seriously and appreciate those issues.
Wonderful. Thank you. And Mike, anything from you to finish up with?
No, I'd agree. I think it's been a great audience. The testament to how much interest there is in this space to see such a terrific turnout. And great work for putting this together.
No, thanks so much. It's been an amazing response. So we just, sorry, go ahead. Was someone speaking? No? Okay. We're just going to share these final slides again, just to remind you of this wonderful offer that we have. For those of you that are really excited about CPAT, and we can see that many of you are, have a look at the testimonials on the course. And here is the slide which encourages you to apply now. And if you want to save an extra $200, please do so by submitting your application by next Monday. Is that visible? Oh, okay, fantastic. And we'll also just go to the patient support slide as well, just to remind you of that. If we can get it working, we're having all sorts of wonderful technical fun. But just to remind you all that we would really love you to, can you pop the gallery back on for me, please? Thanks so much. Just a reminder that our patient support fund, this is the end of the financial year now. We're at mid-May, and you've got 6 weeks where you can make a tax-deductible donation to Mind Medicine Australia or become an ongoing contributing donor. And we really, oh, there it is. Thank you, Scott. And we really encourage you to make that donation. We will keep giving of our time and money as we have over the last many years. But this is a joint effort and it's a movement, and there's many, many people who are suffering. So we need all of our support, and we can all afford a couple of cups of coffee a week at the very least to support those who are doing this tough. And at the end of the day, people won't remember the car you drove or the house you lived in, but they will remember the difference that you made. And we encourage you all in your own way to give as much as you can right now so that we can really move this field forward and gain plenty of data and evidence so that more and more of these treatments become available, so that health insurers continue to be excited, and so that the governments start to provide support as well. So with that, I just want to thank all of you.
It's worth just adding
Yes.
that 100% of a donation to the patient support fund goes to the patient.
Yes.
In other words, there are no administrative costs. There's nothing that MMA takes out of that that donation. It 100% goes to subsidising the patient.
Yes.
And the other thing I should say is that our foundation is prepared to match contributions that are made into this fund. Again, that's
so every $100 you donate, we will match you.
Yeah.
So it's a great incentive. And if there's any big donors out there who want to triple the impact, please reach out to us. But I want to thank now Dr. Lauren Macdonald, Dr. Ali Kotler, Dr. Mike Winlo, our wonderful executive officer, Scott Edwards, my beautiful husband, Peter Hunt, my wonderful colleague here, Ilan Heyman, and all of our team at Mind Medicine Australia, all of our advisory panel, our ambassadors, our lived experience panel, all the teachers on our faculty, and all of you have been part of this movement for the last 5 years. Let's continue to move this field forwards as much and as fast as we can together, as safely and effectively as possible. Thank you all for your great support. And we look forward to hopefully seeing many of you on Wednesday with the great doctor and shaman, Alberto Villoldo. Thank you very much, and have a beautiful evening or day wherever you are in the world. Namaste.